Hi, Beth, and welcome. So good to have you here.
Hey, Pat, great to see you.
Thank you. So, Beth, you've been working on dilated cardiomyopathy and Duchenne and Becker for a very long time. And I think that every parent worries about the heart, right? Because it's a muscle, and obviously in the cardiac MRI, we hear news such as you see strain early as 5 years old. What does it mean? Can you help shed some light about what we know about the heart and the heart disease in Duchenne?
Yeah, I mean, you're right. The heart is a muscle and it is affected in Duchenne muscular dystrophy. But different from skeletal muscle, at least the way I approach it is we have so many more medicines to treat the heart than what we have for skeletal muscle. Now, we're excited. There are many things coming in the skeletal muscle domain, and we have some drugs approved now, but the heart and the type of problem that happens in the Duchenne heart is actually a problem we know very well in cardiology, and we actually have quite a lot of medicines and devices and approaches to treat that problem. And so I think the key part, as any parent is thinking about this, is to just be very proactive, make sure you have a cardiologist who is familiar with Duchenne and the management, the skeletal muscle side of management, as well as the cardiac side. And that's just really important to have somebody knowledgeable about and keeping up to date about what those treatments are.
Do you recommend early cardiac MRIs?
Well, MRIs are always a little bit tricky in the very young ones, because if you require sedation to sit still for an MRI, there's risks associated with sedation. And so luckily, most of the time where we see some of these early changes, it's around the age when most children don't need sedation to do the MRI. So I think that's encouraging. I think many people still remain pretty reluctant to be sedating kids for cardiac MRIs really early in life. And so, part of it has to do with your child and how readily they can sit still and do an MRI. And MRIs can be a little bit scary. You're in a big machine and it makes a lot of noise. So.
Yeah, absolutely. I think that, MRI is suggested to be the gold standard. And I think what gets really confusing is a parent has an MRI and then an echo and tries to make sense of those two tests to say, are they apples and apples? And what can you interpret from each of those? Could you shed a little light on both of those?
Yeah, really, really good question. So echoes, I will say both echoes and MRIs are both very much user dependent. So again, you want to be in a facility that's very used to doing these. And for example, echo is highly dependent on the echo technologist who's holding the probe and taking the images. And they can do even very young children and do echoes if the tech is patient enough and there's something there for the child to be distracted by, or sometimes even a little baby, they can do them on with the parents holding them. So echoes are very, very safe to do, but to do a really quality, good echo on especially a small child, it takes time. And so you just want to make sure nobody's rushing through that process and they're just taking their time and getting the images they knew. Now, you had mentioned strain. And so again, a really good echo, we can see strain differences in really good echo. That's not always done because we do that probably more on the adult side than on the pediatric side, but a good echo lab actually can see some of those really even early changes by echo. But the bonus of an echo is that it's safe, it's really easy to do, and it can be done even on very, very young children. MRI, as you mentioned, gives us more information. It gives us more of the tissue quality, whether we see what we call delayed enhancement or some of that scarring that's present on the heart. And again, probably can see strain a little bit easier, although some of my echo colleagues will argue with me about that and say we can see it just as well on the echo side as in the same. So they're complementary tests. I do notice on the pediatric side, they will order these pretty regularly, once a year or so, even when a child's growing. Lots of things can change. As we get to the adult side, we probably don't do them quite as often. One, because it can be really hard for an older Duchenne patient to do an echo, to do an MRI because of just the need to be flat in the scanner. Whereas some of my older Duchenne patients, we can do great echoes in their chairs and not even have to move them. So that's a good thing. So a lot of it has to do on what your facility, what their experience is, how good are the images. I still get lots of great echo images, and we do that all the time.
Good. Beth, I know you're an adult cardiologist, and so this isn't meant to be, just in your view, as a mom with a child, would you, and I'd come to you with a 5-year-old and say, I'm going to start cardiac meds. Would you agree with that or not?
I think they're pretty benign to be on. If it were me, I would probably say yes, particularly around the ACE inhibitors or angiotensin receptor blockers. I think we know they're extremely well tolerated. I work very closely with our pediatric cardiologists. I actually go and do a family clinic with them. So we work, there are many children who get treated with these medications, and it's a real mainstay for any children with kind of children onset cardiomyopathy. They do this all the time. Very safe, very well tolerated. We usually start with one of those, and then we start talking about adding a beta blocker at a little later state. And that's where I think the pediatric cardiologists don't embrace beta blockers as readily as we do on the adult side, where we pretty much believe everyone should be on a beta blocker because it's good for hearts, manages blood pressure beautifully well. But again, the good news is these are medications that we have decades and decades of safety data. We know very well that they're well tolerated and very safe. And what's kind of cool on the adult side is we've also seen several new medications actually come into our management now. We are now using newer drugs. Probably people have seen some of them being advertised on TV, but this sacubitril valsartan is a newer drug known as Entresto. That works very well for heart failure patients, really remarkable results. And then our other new drug that we use now quite readily in the adult setting is medications that are used for diabetes, which are called the Flozin type medications, which have turned out to have remarkable efficacy for people with heart failure and reduced ejection fraction. So we're starting to even think about using those as well.
And Beth, you're doing a loop recorder study. Can you talk about the loop recorders, and should we all have one?
Yes.
And do you think there are arrhythmias in Duchenne? All of those in one?
So loop recorders are, what we do know is that there is generally, when we look across hearts and we see more scar on the heart, we know that that's an increased risk for having irregular heart rhythms. And irregular heart rhythms can affect the top chamber of the heart in the form of atrial fibrillation, as well as the bottom chambers of the heart in potentially more lethal rhythms that we call ventricular arrhythmias. And so we don't want those to happen. We want to treat them if that's a possibility. We want to prevent them. And so our best defense against those is monitoring for it. And so many people are now more familiar with the patch monitors, which you can wear for up to 14 days. Those are outside the body, and it's a skin patch. It sits on you. Those are now being used in the pediatric setting. They weren't for a while, but now they are more readily being used there. And 14 days is pretty good. Like I get watching somebody for 14 days and knowing that they haven't had anything in 14 days is great information. And then when we do see a little bit of something, or we're not quite sure and we want to get more information, but we don't want a child to have to keep wearing a patch 14 days after 14 days after 14 days, we instead have these little capsules that can go under the skin and allow us more ready monitoring pretty much 24/7. And you can do regular downloads of those little loop recorders. Though what we hope to do is correlate imaging data from MRIs with the data that we're getting, not just off loop recorders. We're actually doing it sometimes on people wearing patch monitors, because we can do those more readily, and all our patients now have the patch monitors, so we can increase our sample size a little bit that way. And we'll be asking that question. So we know Duchenne hearts have a lot of scar on them, kind of more than what we're used to seeing, but we don't necessarily think of the arrhythmia risk as being much worse than other cardiomyopathies. So that's really the central question of the study, which is to try to make those correlations. What we see on imaging, what does it correlate with the rhythms, so that we can better guide our patients about whether they need devices or not.
Yeah, I think one of the questions with gene therapy is, should the gene therapy improve skeletal muscle function? Is the cardiac target useful, and does it increase any risk to the heart?
It would be one of those things I would call a gaping hole in the literature right now. It is something. It is in many ways experiments that are being done real time. And, as we've all lived through pandemic this last 16 months, we've all been living through what it is to be in experiments real time. But for a parent who has a child with Duchenne, that's a bad situation to be in. And we need to get more information. We can get a lot of information from our animal studies where we can model this, and we're trying to learn more about it. Is gene therapy going to equally treat the heart and the skeletal muscle, or is there going to be disproportion there? We have some concerns about some of the animal studies for for antisense treatments. And those, again, are in use right now, but we know they don't quite get into the heart cells as well. And what's that really going to mean long term? And so I think anybody who's been receiving those treatments, if you've been in a clinical trial or if you're actually on an approved drug, I think, really getting together and gathering that information so we can get as much gathered and studied and make recommendations as quickly as we can. I think that's what we want to be doing. We really have to learn more about this.
Thank you so much, Beth. I think the Action Network is collecting this data. Hopefully we will get together, collect the data, and really understand this for kids. We're going to come back to you, and so thrilled that we're going to be working on the guidance with a specific heart cutout. We have so much to do there. Thank you so much for joining us tonight. Appreciate all you do.
All right, take care.
Speak soon.